Heart Talk continues with a talk Alan Taylor had with Dr. Kristin Newby, professor of clinical medicine at Duke University School of Medicine in Durham, North Carolina. They cover pulling it all together, managing comorbidities and syndromes in older patients with stable ischemic heart disease.
Kristin, welcome to ACCEL.
Thank you.
We're here today to talk about care of the older patient with stable ischemic heart disease. To pull that management together, as these are patients who have many comorbidities and often different syndromes for stable ischemic heart disease. So let's talk about a case and define the gaps we have, and then try to deliver some key knowledge to the listener, and we'll end up with a call to action on what we can all do to deliver better care to the elderly with stable ischemic heart disease. So, Kristin, perhaps a case.
So let's think about an 82-year-old woman. She's living in an assisted living facility, but is taking care of all of her own activities of daily living. She enjoys ballroom dancing and does that once or twice a week with her friends. But she has a number of medical illnesses. She has high blood pressure, she has high cholesterol, she has rheumatoid arthritis, and she has mild dementia, which is what prompted her to move to the assisted living facility. But again, does most of her routine activities of living, both managing her checkbook and other things. So mild dementia.
So we're in an outpatient setting, and this is a patient we know, and they're here today because they have symptoms which may be indicative of stable ischemic heart disease. So as the first point of information, how might that patient present as an older patient that would be different than a younger patient in the terms of their stable ischemic heart disease?
So I think there's kind of one major thing to think about, that the elderly, when they present with heart disease, may present atypically. And that means that things like fatigue are really important to tease out when you're seeing an older person, and understanding how their activity level has changed over a period of several months may be very helpful to sorting it out. In this case, this individual, as I mentioned, enjoys ballroom dancing. She does it once a week, but she started to notice that she can't quite keep up as well with her partner during her dancing, and she notices a little bit of shortness of breath while she's doing that. So she's referred for concern that she's developed angina.
So in this instance, we want to put this patient together, and what makes the care of this patient so difficult, I think, Kristin, is that we have gaps in our knowledge. What are the gaps in our knowledge that would most specifically apply to this patient?
If we think about our guidelines and how we apply those, the stable ischemic heart disease guidelines, there are large gaps in understanding medical therapy for the elderly, gaps in understanding how we apply coronary angiography and potentially intervention in the elderly. And we certainly have no evidence about how we apply these standard therapies that we use in younger individuals on the context of the medications that this woman is on for her rheumatoid arthritis and potentially for her mild cognitive impairment. And that's largely because the trials just haven't included that many elderly. So we're left with a situation where we need to take what we know from the trials and outcome studies that we have and try to apply those to an older individual where decisions may have both greater positive effects, greater risk, greater benefit, but also may have greater side effects and downstream effects, including drug-drug interactions and influences on renal function, et cetera, depending on what course of action we take here.
Yeah, the care has to be highly individualized to the elderly patient, given all the issues you've mentioned with polypharmacy and adverse effects. And maybe even our goals of care are different. They're about quality of life. And in that instance, we come up at crossroads because our guidelines and so forth, they point us towards performance measures, measured actions, medical behaviors that can be measured in terms of how often we do them against the number of patients we see, for instance, providing a statin to this patient. But as we think about the elderly patient, performance measures break down because the patient's the expert at what they know, right, their life and what they want. And we're the expert in what we know, which is what could help them. So how do we bring that together And there's this new concept of shared decision-making, and it's a perfect place to put shared decision-making is in the care of the elderly patient.
Yeah, I think that's absolutely the path we have to take. And when we think about shared decision-making in the elderly, it includes the physician, it includes the patient, and in this case, it includes their support, potentially their caregiver as well. So the family becomes increasingly important here as well, because everything we do affects not only the patient, but also potentially what the family has to do to help care for this individual. So this is the prime opportunity for shared decision making. So let's say shared education. So the patient is telling us what they want us to know about what's important for them, what their goals of care, what they want to get out of this interaction, but also for us to do a good job at educating both the patient and the family about what the benefits and risks and opportunities are, and truly that we don't have any one right answer. So perfect opportunity for shared decision making.
And this represents a transition in the ACC's approach to performance measures to shared decision making. So this might be the first opportunity to introduce it to the ACCEL audience, but it indeed is the new way of thinking. The patient is the expert, has their expertise, we have ours, and we bring that together in a way that is most impacts what the patient's after in terms of their outcomes and their care. Let's point towards a call to action then. We've talked about different presentations for stable ischemic heart disease in the elderly, the gaps in our knowledge in terms of evidence, this new shared decision-making model. What could we do that's a little different? For example, we mentioned trial gaps.
I think when we think about trials, first of all, when we have the opportunity as a person who's doing clinical trials, we need to make sure that our trials are as inclusive as possible. So we don't have age restrictions. We try to minimize restrictions based on renal function. We also need to think about how we start doing smarter trials that look more holistically as opposed to at individual types of disease. So a great example there is when we look at atrial fibrillation, we exclude people who need medications that this woman might need for coronary heart disease, like antiplatelet therapy, P2Y12 antagonists. Similarly, if we're looking at a trial that we're designing in stable ischemic heart disease where antiplatelet therapy might be the new drug we're testing, we exclude people who need anticoagulation if they have atrial fibrillation. So smarter trials where we can look more holistically at the spectrum of diseases that might affect the elderly would be good. We can also start to think about how we use the electronic health record to help us bring in a broader set of data, particularly around the elderly. So more comparative effectiveness using existing data. But then I think your concept, as we're thinking about performance measures, we also need to bring into that it may not be so much checking a box, did we use this drug or not? It may be, did we use this drug in the context of what we understand the individual's preferences are and the comorbidities and other mitigating factors that may come in. And I think the elderly just really gives us an opportunity potentially to expand how we think about appropriate use and performance measures.
Right. I think the appropriate use criteria are a place where we could really amplify this, since it bridges the gap between our limited evidence and expert opinion. And elderly AUCs or AUCs, appropriate use criteria for elderly patients, might be quite useful.
Absolutely. I think that could be, the next step in what we're doing. And I think it's going to be increasingly important because the elderly population is not going to shrink over the next decade or so. It's actually going to grow, and we're going to be increasingly faced with scenarios like the one I presented, or even more complicated scenarios. And we know that working in the current environment leads to things that are equally detrimental. Polypharmacy, so elderly on 10 or 11 drugs, which have multiple drug-drug interactions, is just not the direction we want to head. So revising our thinking through a new type of appropriate use criteria that are developed around the elderly, I think would be a huge advance.
So not only do the elderly present somewhat differently, then we don't have the information we need to take care of them in the way that we otherwise would like to inform our decision making. And we're left with a set of circumstances that we need to move beyond performance to shared decision making. In the end, there's a lot of changes here. And we're in Chicago where there's a lot of great street art. And walking out of the hotel today, I saw this great piece of graffiti and it said, "Be the change you want to see."
That should be our mantra.
Well, Kristin, thanks so much for coming to ACCEL today.
Thank you.